history is, you know, we can cut a tooth. If a tooth is broken, we can cut a tooth. If it has a cavity, we can remove the decay. If the tooth broke, we can somehow put it back together. But what it comes down to is the dental materials and what we're going to use to put that tooth back together so that that tooth can look like a tooth, function like a tooth, and hopefully feel like a tooth for the patient. And there's many different ways. I mean, I can do a restoration one way, Dr. Cervantes can do it another way, dentist down the street can do it another way, and it doesn't mean anybody is wrong. It just means, you know, what I like to do, what he likes to do, what materials he prefers, what the patient is willing to pay. I mean, because you can do gold, you can do porcelain, you can do a metal filling, you can do a plastic filling. They're all materials, and they're all going to cost different. The insurances are going to pay different, so it comes down to different things that makes up the decision on how to put the tooth back together so it can look, function, and feel, you know, proper for the patient. And there's tons of materials, and we'll go through some of the ones that we use and some of. But I mean, there's, you know, if you look at a dental catalog for to order supplies, I mean, it's this thick, and you can choose from a whole bunch of different companies and different manufacturers that will make the same material with different, just a little twist to it that's, you know, better and improved, and then 6 months you get a better, and kind of like your iPhone, you know, you get an iPhone, and then 6 months you get a new and improved one. Same thing with dental materials. Hold.
Freezing.
Are you?
Yes.
Everybody else?
It's probably really
I
hard.
can drop it down.
I'm sorry.
Oh, you're okay. I know.
Oh my god, last night I wanted to turn the heater on.
I'll turn it off for a little bit. If it gets warm,
It felt so good. The last 2 days have been like.
I saw her shaking back there. So anyway, again, it basically comes down to what the dentist prefers and what the patient is willing to pay, and it does affect, you know, longevity and how long, you know, the type of materials that you use on a certain tooth may work better on a different tooth. So if you are using a material that you don't feel is going to be good for that tooth, again, it comes down to informed consent, and you tell the patient, you know, I can do this big filling for you, but it may not last, the tooth may break, and then we're still going to do a crown, you know, down the road. But if that's all you can afford right now, it's better than, you know, taking a tooth out. And some patients will come in and they say, if you can't do a filling, if you can't do a big filling, I just want the tooth taken out. Well, you know, I obviously don't want to take the tooth out. I'd rather do a big filling, and, you know, if it gives him a year, 5 years before it breaks, then, you know, then hopefully by then he can afford, or she can afford, to do something better. So even though at that point a crown or a total tooth coverage may be indicated, the patient can't afford it and we can do a different type of material, I'll do it as far as the patient understands that that's not what's indicated, and they take the risk. So again, there's a lot of materials. So we'll start basically from the bottom up here, and I guess we got to update our fires. So once we remove, or we have a cavity and we have to start to restore, this guy is going to determine a lot of what we do to the material that we put on the tooth, because the closer we get to this guy, which is the pulp, will determine how sensitive the tooth is, whether the tooth will live or die, or not the tooth, but the nerve. Okay, because the deeper the cavity, class 1, class 2, class 3, you know, or class 4, the deeper it is to that nerve, the more trauma that tooth is sustained, and the more likelihood that that tooth may die with, you know, our filling or material that we put on there. And so a patient may come in with a cavity that's, you know, down to here, and the tooth is asymptomatic, doesn't hurt, hasn't hurt, never has hurt, you know, or so they say. So obviously we take a picture and we show them a picture on on the screen or take an x-ray and say, this tooth has a big cavity that needs to be restored, or it doesn't bother me. Well, it will one of these days. So we go in here and we put a filling that's going to come down, you know, to the bottom. You know, my filling, my cavity preparation is going to come down and just get really close, and then we're going to fill it with whatever we fill it. And so numbing medicine wears out, and the tooth begins to hurt. Okay, and the patient comes in the next day and they're mad. That tooth never bothered me until you worked on it. You know, well.
It'll stop bothering you.
Well, hopefully, but it may not, because us going in there to clean this tooth may have just pushed that tooth over the edge. You know, because it had the insult of the cavity or the decay and the bacteria, and we go in there to clean it out with a mechanical burr and spoons and stuff to clean it out, and it may have been just kind of teeter-tottering between going bad and staying good, but our work just kind of traumatized that nerve a little bit more and pushed it over the edge. Again, anytime we're dealing in here, you're going to get inflammation when we work on that. That nerve will swell up a little bit, so it'll be a little bit sensitive usually following the work that we do, but hopefully that goes away. But sometimes it may not, and we just have to advise that patient, this is a deep cavity. You know, we're going to go in there and clean it because it needs to be restored, or you're going to need a root canal for sure, or take the tooth out. So I may go in there and the tooth may become symptomatic after I treat it. So again, we have to tell them up front before I go in there, because if I don't tell them, the day after they're going to come back, that tooth never bothered me until you drilled on it. And then what do I say? You know, it's nothing I did, it's just that that's just the way the tooth responded. So again, when we're going to put something on there, we try to protect the nerve, okay, from the materials that we put. Okay, so that's what cavity varnishes and liners do. When we're so deep, we try to put like a medicine down here below to protect the nerve and try to keep it alive and prevent it from any material that we put on top. But some of the materials, the cements and the amalgams, and they're either acidic or their pH isn't the same, and they'll cause some nerve inflammation. Okay, so that's what these guys do. Okay, so a cavity varnish is composed of natural gum or resin and seals the open dentin tubules. Okay, if you remember the dentin, it looks like little canals. Okay, and all we do, we brush it on after we clean it. We brush it on down here so that we can seal any dentin tubules. And I'll show you a picture right now. They're little canals that are filled with fluid that go down directly into the nerve. And when we're so close, we try to seal them, again, to prevent some sensitivity and prevent more bacteria from going in through the tubules to the nerve and causing some discomfort. So the purpose of the varnish, one, prevents or decreases tooth sensitivity, again, because we're sealing those tubules. It also prevents discoloration of the tooth structure by sealing the tubules and preventing the metal ions from penetrating. That's if we're using a metal filling, okay, these metal ions. So if we're using them, and you may have seen on somebody, when somebody smiles, you'll see somebody has a silver filling and that tooth looks gray or dark. Well, what's happened is some of those metal ions have penetrated through the tubules to darken the tooth. Okay, whether it was sealed or not over time, it probably, that has happened. So this tends to minimize that. And there's different manufacturers. Varnol is one. Copaliner is another one. Copalite, this is the one you'll find in our drawer and the one we'll use later today when we do amalgams. This is the one we do. And again, you prepare the tooth, and then on a little cotton pellet or a little brush, you dip it into the bottle, you hand it to the dentist, and he coats the tooth, dries it, coats it again, you know, 1 or 2 coats, and then you put the filling over it. Again, so the varnish does what? Decreases sensitivity by covering the tubules and minimizes discoloration. Okay, that's on the test. This is what a scanning electron microscope image will show on the dentin. Okay, and those are the tubules that we're trying to seal. Okay, so those tubules are there. So here's kind of my drawing there. Here you have your preparation, however it may look. And what you want is a nice sealed restoration with whatever material. Okay, if it's sealed, you're usually going to minimize the sensitivity. If it's not sealed, you're going to get moisture, bacteria down underneath that restoration and causing some sensitivity. Okay, so whatever it is that's used to seal, that's what it does. Okay, so that was a varnish. Okay, and varnishes are usually for metal restorations. Okay, we probably won't use a varnish for a tooth colored or a composite restoration that we'll talk about in a bit. So the varnish is for an amalgam or a metal restoration. Okay, a liner is for either. Okay, and it's just a different material. So a cavity liner is similar to a varnish but contains calcium hydroxide, zinc oxide, or glass ionomer. Okay, and all those do different things depending on what you're using it for. The calcium hydroxide liner, which we'll show, is, again, we use it usually underneath a metal filling, and that it's not real important or anything, but if you're doing an amalgam, a metal filling, this is the liner we're probably going to use, especially if it's really deep, and I'll show you why right now. Zinc oxide you can use with, again, amalgam as well. Glass ionomer is probably what you're going to use with the composites. And again, the liner, here's a glass ionomer. This is the one we have, Limelight. Again, if it's really deep, basically what we're trying to do is protect or insulate or protect the nerve. So we'll put a little thin layer of this on the deeper areas there to prevent whatever other material we're putting from doing damage to the nerve. So again, here's the pulp. Okay, you can kind of see the tubules in that image there, and you just kind of flow a little liner over it, hit it with a light, some self-cure, depending on what you're using. And again, you're just protecting that nerve. Okay, calcium hydroxide, this is an important one, because anytime we're really close to the nerve, we need to put something there that's going to try to basically put a band-aid on our tooth there. And you'll see it, and I'll show some pictures. I don't know if on this lecture, but when you clean out the decay, sometimes you're so deep and you're getting so close to the nerve that it'll look pink. Why? Because you've got blood supply. Anytime, and we call that blushing. And that's what we'll put in the notes, pulpal blushing. Okay, we didn't actually go into the nerve, but I could see the redness underneath that. If I would take my Explorer and poke, I'd probably poke right through it, and then I'd get bleeding. Okay, so pulpal blushing we use, and that tells us we're really, really close. But this is a substance that's placed on the deepest part of the cavity preparation. So wherever we see the redness, or if we think we're pretty close, where it stimulates, this is the important, it stimulates formation of secondary dentin, basically a bridge or a scar. Okay, so the tooth, again, remember, down here you've got, between the dentin and the pulp, you've got cells that generate dentin. So you put that there and it stimulates those cells to produce a little extra dentin to shield itself from that restoration. Okay, so it's used as a liner for amalgam restorations, the calcium hydroxide. And the reason we can't use calcium hydroxide, you can, but you're not supposed to, underneath a composite or a resin, is because it doesn't allow it to cure. Okay, it affects, if you hit it with a light, everything else is going to cure. Right where you have the calcium hydroxide, it does not set up. Okay, and if you have a restoration that's not set on a tooth, it's going to cause some sensitivity because you have flexure, which you bite down and you put pressure on that.
Like a spring.
Yeah. And what happens to the liquid or the fluid that's inside those tubules when you have like hydraulic pressure, you bite down, you get hydraulic pressure, the fluid that's inside those dentin tubules, you're gonna put pressure, it's gonna go shoot that fluid down to the nerve, and it's gonna bing, and every time you bite down, you're gonna go, ow, that hurts. Why? Because you've got flexure underneath there, so you never want something that does not set underneath the filling. So it prevents the setting of composites or resin, so that's why we do not use it underneath. And this is what we have, it's Dycal, and anything that's a tube in a tube, usually it's a base and a catalyst. When you mix it, you put the same amount of each, okay? And usually that's more than enough. Okay, it's just a little dab of that and a little dab of that, and you mix it really quick so that you get rid of all the streaks. And then you hand it to the doctor on a little Dycal instrument, and he places it right where it goes. So on this, again, another diagram, here's the preparation right here. That's a dental amalgam, a metal. Now right here, this is the deepest part, okay? The cut comes through here, down to here. Here's where we probably would have pulpal blushing, and then it comes up this way, okay? So right there is where the Dycal would go. That little blue triangle, or whatever it is. Not a triangle,
Just the depression.
I'm trying to remember my geometry. Yeah, no, hexagon would be six-sided. And 1, 2, 3, 4. Polygon? Is that polygon?
Sure.
All
go
right.
there.
All right, I'll have to ask my son. He's taking
Or parallel.
right
You
now.
could probably tell us
Parallelogram?
that and we would
Maybe,
all listen and
parallelogram.
guess what that is.
Yeah, one of those. Anyway, it's not a triangle. I know that.
Or a rectangle.
Or a no, it's
bent
not a
square?
rectangle. Huh?
Oh, bent square.
A bent square, a crooked square. There you go.
Kite shaped.
Anyway, that's where we would put on the deepest portion. And why are we putting the calcium hydroxide? For the pulp. But it does what? Prevent sensitivity, but something else.
You know.
It stimulates
Dentist help.
secondary dentin formation.
There you go.
Okay, so it's going to try to form a scar here. So the nerve is going to start to kind of shrink. It's going to form dentin, and the nerve will start to shrink away. So that by the end, if we put calcium hydroxide here, the nerve over time will drop down. It'll look something like that. Okay, so it's trying to push itself away from whatever filling you put. Okay, so you're going to have secondary dentin formation in that area. And that's why when you take x-rays, sometimes the ideal shape of the nerve is like this, but you know, after 6 months, the nerve is going to do this and it's going to drop down this way. Okay, it's going to shield itself away. And that's just the body's way of healing itself. And it may or may not live. You know, it may die and you need a root canal. Kind of the same thing here, just a little different. Okay, here's the nerve. You put the liner, calcium hydroxide or whatever, or limelight, and we'll talk about a base in a bit. This is kind of what the limelight looks like. Okay, you have a cavity preparation there, so anywhere that you think it was too deep, you put a liner there underneath it. This one's not that deep, so nothing was put. Okay, this is what calcium hydroxide would look like. It's more like a milky material. Okay, this bonds to the tooth. This doesn't bond to the tooth. I could scrape this off with a spoon. This one This one I can't. That one's bonded on. That's what again, this is for a tooth-colored filling. You could use this under metal as well, but you can't use this under plastic, under resin. So something like that, you know, you can put your tooth-colored filling over it. Here you would use probably metal. You can't put a tooth-colored filling over calcium hydroxide. Okay, questions on that? So this you've got the varnish first. If you're not putting anything, if you have pulpal blushing, you're going to put this before and then varnish. Okay, we'll go over that in a bit. Questions? No. Clear as mud. Okay, cements. Okay, so that was varnish and liners. Now we have different cements that we can use. I should have covered base, so anyway, a little bit out of order here. But zinc phosphate cement. This is an older cement. This is what I used to use in dental school when I was back in '88. So this is what we would use for the most part to cement our crowns in dental school. It's a powder and a liquid. There's a type 1 and a type 2, and that's what's important for the test. Zinc phosphate cement has a type 1 and a type 2. The type 1 is a fine grain that easily flows into the small internal irregularities of the restoration. Okay, so the type 1 is what we use to cement crowns and bridges. The type 2 is a thicker grain, and you can use that for like temporary restorations. Okay, so it's a little bit thicker material. It's still considered a cement, but it's thicker. Okay, so this zinc phosphate cement would be type 1. I thought I had a type 2. Hopefully we'll come up with a type 2. Would be IRN. Okay, another type of cement is zinc polyacrylate cement. Adheres directly to tooth structure through chelation. Okay, chelation means that there's a chemical reaction with the tooth structure itself, and they exchange ions and they bond. Okay, so you actually get a bond to the tooth structure. Okay, it can be used to attach orthodontic brackets to the tooth itself. Again, this is the older type of cement. But the important thing is that zinc polycarboxylate cement bonds to the tooth through chelation. Okay, ZOE, zinc oxide eugenol, okay, contains eugenol, which is found in clove oil. Okay, has anybody smelled clove oil before?
Yes.
Yeah.
And I've also heard people when they have toothaches,
They
put
put,
clove oil on it.
yeah, they
It
put,
helps.
yeah, and you can buy that at Walgreens. You know, when you go to the dental section there for the temporaries or any type of dental emergency, you'll find a little bottle of dental material that's got oil of cloves. Okay, why? Because it soothes the nerve. If you've got a tooth that has if you have a toothache and you put, you know, something that's got clove oil, it will soothe the nerve and take out, you know, some of the pain. That's why ZOE, we use it as a temporary, like on this restoration. If the patient had been having a little bit of symptoms, you know, clean it out, and I'll say, you know, we'll clean it out and put a medicated filling and see if the symptoms go away. If they go away, we'll fill it. If they don't go away, you need a root canal. So this is what we'll put in there it's just like a medicated filling. We can also use it as a base, okay? A base, again, you have your liner and then your varnish, and then if we need something a little stronger, then we can put a base, which is just a little thicker layer that's, one, going to flatten the surface where we're going to put the restoration. If you have kind of a really bumpy preparation after you dig a hole here for decay and dig a hole here for decay, you know, you try to level the floor off to put your filling material on, and so you put a base is what it's called. Okay, so applied to cavity preparation after a liner is placed. And again, we're just trying to build a little bit of bulk to protect the nerve from any dental material. And again, you can use some calcium hydroxide, zinc oxide eugenol. These are the other materials that you can use as a base. So this was a picture we just saw. You've got your liner, and then you just kind of level off the floor to give you something a little bit nicer to put your restoration on if you need. You don't always need a base. Again, it just depends on what your preparation and where the decay goes, if you want to do it. Okay, some other cements are surgical cements and periodontal dressing cements. These aren't, you don't really need to know these much. But if you do have gum surgery, there are certain types of cements that you can put over the gums just to protect the gums so that they're not as sensitive following the surgery. And again, you've got eugenol, which is, again, oil of cloves. You've got benzocaine, which is a numbing medicine, zinc oxide, and antibacterial properties. You have cements that are light cured, and you've seen our lights. We'll talk about that. But so here's a case where a patient had a gingivectomy to reshape the gum tissue, or maybe take some pigmentation away from the gums, and that hurt. That would hurt. I mean, you can imagine once the numbing medicine wears out, your lip rubbing on this is not going to be very comfortable for 4 or 5 days. So they're just covered with this cement. You kind of cake it on there just to protect it and soothe it, and it's got eugenol, and it's got a anesthetic to keep it a little comfortable while it's on. And after a week or so, that comes off, and you can at least eat. But at first, it's not going to be very comfortable. So again, that's why that was done. You can see the pigmentation here that they didn't like, especially on their upper. And this isn't the same patient, but this is normally what they do it for. Get rid of that darker pigment, and then you have a little nicer looking gums on.
And is that just from melanin?
Exactly. Yeah. Usually African American. And not everybody. Some it bothers, some it doesn't bother. Okay. Glass ionomer is another cement, and this is one of the better cements when it came out. And GC, the manufacturer, is one of the leaders in this type of cement. We have a lot of GC products here in our office. And again, the important thing is that these glass ionomer cements, they bond to enamel, and they also bond to dentin. Okay, so that's kind of what we're looking for in an ideal world. We want something that's going to bond to the tooth, the dentin, and enamel, and also to the restoration. Okay, because that's going to give us a better seal. It has a high strength, plus it doesn't dissolve. Because saliva will slowly dissolve a liquid or a cement, and you don't want that. Because even though we can close the margins on a crown, microscopically, they're not closed. If you took a really powerful magnification to our crown margins, they're not closed, they're open. And so what's closing them? The cement. And if you have a cement that's soluble in liquid, guess what? It's going to wash out right at the margin, and that restoration is not going to last as long. So you want something that's strong, that bonds to the tooth, the restoration dentin, and it's not soluble. The other thing is you don't want it to be too thick. Okay, you want a thin film thickness, so when you put it on the restoration and you push it down, you're going to get everything to wash out, but just a micron thick layer of cement that's still going to be strong and not soluble, bonding. Because if it's too thick, or if the material is setting up, if you don't mix fast enough and the material is setting up and it gets thick and you go to seat your restoration, it's not going to be flush with your tooth. You're going to have, too thick of material underneath there. When you go to check the bite, you're going to have to grind it because it was too thick. So you don't want it thick. And when we send crowns to go to the lab, they allow for this cement. So what they put what's called a spacer on the model that they make the crown on. They'll paint a real thin layer of like fingernail polish type of deal over it to allow for the cement. So if you have too thick a cement and you go to seat it, again, you can imagine the crown, the restoration doesn't seat flush on the tooth because your cement is too thick. So you want low film thickness. Okay, it's got to be compatible, biocompatible with the nerve. Okay, you put a cement here that the nerve doesn't like, patient's going to be back the next day. It's like, whatever you did to that tooth is killing me. So we want something that the pulp is going to like. And again, you can use the glass ionomers as a base, as that one picture I showed you that would have the tooth colored liner. That was a glass ionomer. So it can be used as a base. The other really good property that glass ionomers have is they release fluoride over time. So what does fluoride do? Yeah, it helps in preventing cavities. So what better thing to have underneath your restoration than something that's fighting decay or preventing cavities? Okay, so that's the good thing about glass ionomers is they release fluoride, so they help you minimize recurrent decay underneath your restorations. Again, this is one of the older Fuji 1 was the first one they came out with, and this is to cement your crowns and your bridges. And it used to be that you mix, you know, one powder, one scoop, or it's 1 drop to 2 scoops, I believe is what it is, and it'll say right on top of the bottle right here how many drops and scoops. And so you put it on the pad and you mix it till it's like a creamy consistency. You know, 10-15 second mix. You don't have, you know, a minute to mix. It's pretty fast because it starts to set as soon as you combine them. That's how you used to mix it. Mike probably will have this, but he'll probably have the newer material, which comes in a capsule. And you put it in a little machine and it makes it for you, and you have a gun and you squirt it out. Okay. Hand mixing is usually not a lot of materials that we hand mix anymore. The only one would be the IRM or the calcium hydroxide, the DiCal, the IRM, which is the zinc phosphate cement. And you're going to mix that today because we use that all the time as a temporary. So this one is Fuji 1 is to cement crowns and bridges. So you mix it, you put it inside the crown, and some of you guys have seen us cementing crowns. So the cement is mixed, and then you put it in the crown, hand it to the dentist, and he seats it on the tooth. Okay, GC Fuji 2 is more of a restorative material. It's not a cement for your crowns. This is to put on a tooth that has a cavity, and usually we'll use it on root surface because, again, it bonds to dentin, where composites don't bond as good to dentin, or didn't used to. Now they bond a little bit better with the bonding agents, but this was, back then, you would use a glass ionomer on the roots because it bonded to dentin and enamel. Okay, and again, here, you know, the newer capsules are here. You can also do the powder, but these capsules you activate and you put them on there. One thing that was not good a while ago with this is that it wasn't very aesthetic. Okay, the glass ionomer, you can see here, class 5 restorations, and they look kind of milky and chalky. Okay, but it was good back then. Now patients may not like that. You know, they want it to look tooth colored. So some of the newer composites and some of the newer glass ionomers will come in different shades, and he'll probably have different shades. They're A1, A2, B1, B2, whatever the shade may be, and you place them down there. So this is kind of, again, class 5 lesion, and that's probably a glass ionomer. There.
What was the package?
Package. That was supposed to be here yesterday.
Oh, sorry. Yeah, they must have shipped it yesterday. Sorry about that.
No, that's okay. Thank you.
Sleep.
Welcome. Have a nice week.
Thank you, you too. And we'll talk about this right now. And then you have GC Fuji 2 LC. The other bad thing about those glass ionomers a while ago was that you put it on the tooth and you had to hold everything and retract and keep saliva out of there because they sat up by themselves. Okay, and so even though they do like a little bit of moisture, you couldn't, like, you know, tell the patient close. You had to control some of the moisture. But LC is light cured. Okay, so now you can put it on the tooth, zap it with a light, and it's done. So you don't have to wait for it to set, you know, a minute or whatever it was. Because a minute in dental time is a long time. If you're having to keep saliva out and the patient's trying to swallow and they got their mouth open, it's yeah, that's, you know, 10 seconds and it should be out of there. So when LightCure came out, that was a big plus for the Fuji. Okay, so glass ionomers. Questions on glass ionomers? Big thing is that they bond to enamel, bond to dentin. Okay? And release fluoride. Okay, composites. What are composites? Fillings that look like your tooth structure and behave like your tooth structure. Okay, a lot of the restorations that we replace nowadays are the metal fillings, and some of the bad things we'll talk about those is that they expand and contract just like any metal, and they cause stress fractures on the tooth over time. Initially it's good, over time it weakens the tooth. Okay, so one of the benefits about composite is that you're actually bonding to the tooth, and you're actually strengthening the tooth by actually bonding to it. Now if it gets too big, then it's not good, but any conservative restoration with a bonded material is good. And it's used for anterior and posterior, okay? The only bad thing is that insurances probably don't cover your posterior composites. They think of that as cosmetic, and they're going to pay for a metal filling, and then the patient has to pay the difference. Okay, so we have to tell the patient, you know, you're insured. This is what we want to do, a tooth-colored filling. Is this what you want? Yeah, I want a tooth-colored filling. Okay, your insurance is only going to pay for a metal filling because they say that it's cosmetic dentistry to put a tooth-colored filling in the back, which that's bogus. But I mean, that's them not wanting to pay. So they're going to pay on a metal filling, and you got to pay the difference. Is that what you want? Most of them, that's what they want. I mean, it's not a big difference. It's, you know, $15, $20, whatever the difference may be. But still, you know, you're doing 4 or 5 fillings, it ends up being $100 out of pocket more than what they would pay. So, but you can do it anterior and posterior. Polymerization means setting it up. Okay, when you polymerize something, means that you allow it to set by whatever means. Okay, and in dentistry we use a light. Okay, a curing light. And if you've been here, you've seen us using that light, Dr. Cervantes or myself. You put the composite in there, and you go for 1 beep or 2 beeps. They're timed, and it's a blue light. Normally we put a shield because you don't want to be looking at the blue light for too long, because it does over time affect the retina. That blue light, looking at it too long, it does cause retinal damage. And that's why there's that amber shield that we put, or it's on the gun itself. But all it does is it sets it up, polymerizes it, brings it to a hardened state. Okay, so you have this image, it's in your book. Again, here's a fractured tooth. What type of fracture is that? You guys remember? Bonus point.
Is it?
Class what?
Is it 3? Class 2? 4.
4. Yeah.
Oh, I forgot about this shit.
Class 1 and 2 are, you know, class 1 is a one surface on the pits and fissures, or the lingual pits of anteriors, or a buccal pit on a molar. Class 2 is interproximal between the back teeth, right? In between the back teeth. Class 3 is just like a C right here. And class 4 is when the angle breaks.
Middle chip, yeah.
Yeah, so a class 4, it includes the incisal angle. And then class 5 is like those that we just showed with the glass ionomer by the root. And class 6, cusp tip. Yeah, cusp tip or incisal edges. Yeah, good. Remember, yes. Okay, so then that's what we would do. We would put the composite on it, shape it, hit it with the light to polymerize it, and it hardens it. We shape it, you know, sort of final, and then you hit it, and then we hit it, then we cure it or polish it with discs or a finishing burr, and then you have your final restoration. And we're going to go through that today. You know that. Okay, the other type of restorations are pit and fissure sealants, and some of you probably have sealants in your mouth. Okay, and all we're trying to do is seal those pits and fissures on the biting surface or the occlusal surface of the back molars of either baby teeth or adult teeth, so that we prevent bacteria from staying down in there. Okay, Some kids have really deep grooves and pits that, there's no way for them to keep it clean, and they're really susceptible to the decay. Whereas others, they'll have nice round, not very well-formed anatomy or pits and fissures, and so you don't need to seal it. And it just depends on the patient. I had a patient yesterday, and our hygienist said, he's got really deep pits and fissures. Do you want to seal it? And I said, no, because these were his 6-year molars. He has not had cavities on his baby teeth. There's no real staining, and I don't like to seal it just to seal it. Just because I'm going to make $200. If he doesn't need them, he doesn't need them. Now, if he comes back in 6 months and I start to see a little staining in those grooves, and I told the dad, if he comes back in 6 months and I see staining in those grooves, we're going to seal them. But sometimes you put a sealant, and if the sealant doesn't leak or it starts leaking, then you have another problem. Then he's definitely going to have a cavity. But some of these kids, especially nowadays with fluoride, they don't get decay. So why am I going to put something there that is only adding to the possible problem? So until I see something, then I'll seal. 20 years ago it was seal everything. You just put a sealant, it's good for not me. But you get some dentists that, and as an assistant, you'll be able to seal. Okay, and you'll go to an office and they'll say, put sealants in all the premolars and all the molars, whether they need it or not. Again, their philosophy. Not me, but you may go there as an assistant.
It's a more old-fashioned.
Exactly, it's a moral, and you'll have to decide, is this where I want to be working, and it's a job, so that's a decision you'll have to make. But again, it's just the morals and the ethics that issue that comes into play there. And I'm not saying everybody does it, but I know I see kids come in here with sealants on everything.
Like, why?
They didn't have anything. But oh well. So again, the important thing is that the sealant must be placed on a clean, acid-etched tooth surface, then hit with a light to polymerize it for it to bond. Okay, that's the test question. Must be clean, etched surface. Okay. What else? Sealants. That's it. So anyway, GC again puts out a sealant. We don't use the GC sealant because again, I don't do too many sealants. But I do have a sealant gun, and I like the sealant that I use. I do like because it comes out pink, so I can see where it's going, and then you hit it with a light and it turns white. Okay, so it gives me a little indicator when it's set up. But GC, it's a good product, and we just don't use it. So here, this is probably where I would probably recommend a sealant. You have a patient that comes in after a recall, and you start to see these little beginnings of decay here, a little stain down in the deep grooves and pits. Okay, so they're not very deep, so I'd go in, I'd show the mom a picture like this, and I'd go in there and I'd clean these out a little bit, just with a diamond burr, roughing them up and make sure I clean that decay out. And then you put your sealant. That's not the same tooth, but you kind of seal there so that you don't get bacteria down in there. And this may be a little too much sealant. I like it right down on the grooves and pits. Because the sealant is not a really strong material, and if you have your upper tooth or lower tooth hitting right here, what's it going to do? Crack it. And if it cracks, then what happens? You get bacteria that leaks underneath it. And if they don't come back for a year or two, guess what? So you want it, and that's why, and I think on one of our tests, it does say, do you check for occlusion, or you check the bite after you do sealants? And the answer is yes, because you don't want your contact right here, because you're going to break the sealant, and it's going to do more harm than good. Okay, amalgam. Okay, amalgam is what? Nobody likes. Okay, well, actually, I had a patient, I don't know, the mom brought the patient in for exam, and I've known the mom for a long time. A young girl, I think she's 13 or 14, and she wanted amalgams because that's what the insurance paid. They're both lawyers, the mom and the dad are both lawyers. 14-year-old putting amalgams on nowadays, it's, you know, kid's gonna hate the mom, you know, forever. You know, even though it's in the back teeth and they're not really seen, they are seen, you know, sometimes. Patients, you know.
My mom knows him and she was always like,
Yeah. And amalgams, I mean, it's a good restoration used for, you know, over 100 years. I mean, it's a good restoration, but nowadays, it's not.
it's not aesthetically pretty anymore.
Exactly. Exactly. And again, over time, it expands and contracts, causing some tooth fractures over time. You know, so you, especially on a young, you know, 13, 14-year-old girl, small conservative fillings. In order to put a metal filling, I've got to cut more tooth structure than I need to cut to get the filling to stay, because the metal is not bonded on. I've got to create my undercuts. I've got to make it wide enough and create little undercuts so that that filling doesn't pop out, because it's not bonded on. It's just wedged in there basically. Whereas for a metal filling, I can just remove the decay, remove any weak tooth structure, and bond onto it, whether it's this thin or, you know, that thin. So I'm actually doing more harm by putting an amalgam on a young tooth than if I put a composite. But they're both lawyers, so I wasn't going to argue. Okay, so the dental alloy is one of the oldest restored materials. It's composed of silver alloy that is combined with mercury. Okay, and that's the bad thing, but it's really not that bad. I mean, I still have amalgams in my mouth that I had done years ago, okay? If they're still doing good, you know, they're still doing good. Eventually they're gonna come out, but I don't replace amalgam just to replace them. You know, if they're cracking or if I see shadowing, then they need to be replaced. But some amalgams are good, but the mercury really depends on who you believe. You know, mercury, once it's mixed with these other metals, it becomes a stable, and there's less contamination. They can measure the mercury when you chew mercury vapors, but you get more mercury out of the environment or eating fish than a mouthful of amalgams. And they've done that study with sheep that grind their teeth. You know, and that was the big study that caused this mercury scare, because the mercury, they measured it on sheep that, you know, kind of grind, and they had sheep that had metal fillings on all their teeth as subjects. And then they would measure the mercury vapor on these sheep after they ate. So they would get these high levels of mercury. But why? Because they grind. Okay? Whereas as humans, we chew. So we don't get the same, you know, breakdown of the metal fillings as sheep do. So
Unless you're a grinder.
unless you're a grinder. But you're still not going to grind, you know, like that. So anyway, the composition of dental amalgams is silver, tin, copper, and zinc. Okay, and that's on the test. Okay. Be right back.
Yes. Yes.
Okay, so amalgam, the definition of an amalgam, whether it be metal, it could be an amalgam of dirt. Amalgam means just a mixture, a combination of different things. Okay, so an amalgam alloy is just a mixture of these metals. Okay, so that's what amalgam means, just a mixture. You can have an amalgam of Chinese food, amalgam of food. You know, it's just kind of like a smorgasbord. Okay, this is the instrument that we use to mix that amalgam. Okay, it's called a triturator or amalgamator. It's a specially designed machine used to combine the dental alloy with mercury. Okay, so in the little capsules of the amalgam, these capsules are pre-measured, they're sealed, and they're inside, they're divided into a little compartment where you have the mercury by itself, then you have the powder amalgam over here. And when you put it into that triturator or the amalgamator, yeah, it breaks the barrier, and the mercury combines with the powdered metal, and it makes it an amalgam. restorative material that we use. And I'll show you a picture right now that condensing
No, we skipped over capsule.
capsule. Yeah, capsule is just their pre-measured container with the metal and the mercury. Okay. When we restore with amalgam, it's called condensing amalgam. Okay, why? Because we put it in the preparation and then we condense it and press it together. Okay, we tried to put as much amalgam into that cavity preparation. And as you're condensing it, you're squishing out any liquid. Okay, so you're trying to get out as much of the liquid mercury as you can. You condense it, and you'll see it kind of, all the runny stuff where the soft material come up to the surface, and you wipe that down and suck that up with a high volume suction. You put in more in there, and you condense it, and you compact it and press it there. Has anybody had an amalgam placed on it? No? Wow. Like me? Well, if you do, or when you pack it here, you'll feel it. And I remember when I used to have my rest of my dental work, when they're condensing it, it sounds like when you're walking on snow. You know how you press it and it goes, and you feel that crushing. It's kind of what we're doing with the metal, and it feels like I just feel it kind of mashing all that metal together. Let's see what's important here. Correct cavity. Saturated amalgam must be packed or condensed using specialized instruments into the prepared cavity. So again, here's a cavity detected. You cut into it and you make your cavity preparation. Once it's prepared, you put your liner or base or whatever you're going to put, and then you pack. Here's a carrier. We'll show you those instruments in the lab. You put it in there and you start condensing it. And that's why it's called a condenser, one of the instruments, condenser. And that's nice, pretty silver film. Okay, take a stand-up break.
No, I started to.
Wait, that is too.
Hungry?
I ate the bowl of granola cereal and then yogurt with granola on top of it and a little. Didn't have one. Granola bar. There's a lot of granola this morning.
Supposed to send this overnight, and it didn't get there overnight. How's on?
I was gonna ask you if that FedEx guy
Yeah.
came in with back here.
They just,
Wilson's coming in, he came in, when I stepped out, he was gone. Just wondering if that was it.
that was it.
How do you wanna do the afternoon sometime? Just set up the first.
Well, Mike will be here for the first part, probably for first hour. And so then we need to set up, probably 4 minutes.
Or that is, do you wanna do composites and amalgams, or just composites? So I can set up this one.
Whatever you want, if you just want to do one and I do the other, or we can do whatever you want. No matter. I'm pretty flexible.
maybe throughout the day it's doing better, obviously, but yeah. Yeah.
I took that all.
Yeah.
And then it's started to fall from that's last night, cause my birthday was on Wednesday. And then, my husband's birthday was yesterday. So, like, we didn't, like, cause we were doing stuff, and last night I'm like, crap, I need stuff. And I woke up super early this morning.
See, I tried to do that. I tried, I really did, but I got screwed last night. My ex, we just got divorced like last month. We haven't been together in years, but it's like a really weird story. But we got divorced last month, and he's supposed to pay child support for our son that we share. And he like texted me and was like, "Oh, well, am I supposed to just give you the money?" And so I'm like, "No, like you're not supposed to just do that. If you want to give me more money, then sure, I'll take
Go
it."
ahead, I'll take that.
Yeah, but I don't want, him to like throw a fit because he's very dramatic. He is. He's so emotional. It's ridiculous. So last night he was like telling me, "Oh, well, I didn't get the papers to turn into my work, and you're a liar. You didn't give them to me." And was like, "Oh, the papers I have are different than yours." And like trying to accuse me of fraud, and like I had to like legally give him these papers.
Yeah.
And just sign an affidavit stating that I did it. And so, and like, if he doesn't have these freaking papers, like, I could get in trouble. So I was like all tense, and I woke up at like, I don't know, 4 or 5 this morning, waiting for 8 o'clock to come around, trying to study. Didn't happen. Did not happen at all. I know. And then I finally was able to call the clerk's office at 8 and let them know the situation. And they're like, "No, you're good." It's like, okay. And they're like, if he has a problem, he can call us. And
That's good.
That's actually, doesn't the court or the lawyer like send the paper to him, like, not even?
I guess they served his work. I didn't know I don't know how it works. I'm not the one who has to pay.
Yeah, you're not the person on the other side, so you don't know.
For child support?
Yeah.
Yeah, they serve me right. My sister works at child
I
support.
didn't know.
My sister works at child support.
Well, no, because
Totally.
my ex was like trying to pay me money, and you can't do that because I know you can't do that because it has to go through the clearinghouse.
Well, you can, but it doesn't count.
Well, it doesn't count exactly, and even if you say it counted, like they don't care. They're like, whatever, that's on you, buddy.
Yeah.
So basically, there's just that, and I was like trying to tell him that I think that there's a paper because I asked the judge when I was there if this paper goes to him or goes to the work, and they said yeah. So.
Yeah, no, the
It's
court
triggered.
automatically sends that. As soon as the judge
Nobody
orders
told
it,
me.
as soon as the judge orders it, the child support office serves the person's job with the papers saying they gotta do the second job.
Yeah, no, I had no idea that that's how it worked, but he was like sitting there accusing me of like not giving him papers and like